Hello and welcome to the Evidence-Based Urgent Care Urgentology podcast. I'm Joe Toscano. I am on the editorial board of Evidence-Based Urgent Care and also the senior research editor for the sister EB medicine publication, Emergency Medicine Practice.
And I'm Tracy Davidoff. I'm the editor-in-chief of Evidence-Based Urgent Care. Joe and I have been involved in urgent care practice and education for many years, and we're really excited to bring to you this new program from EB Medicine, the Evidence-Based Urgentology podcast. Our goal for this podcast is to review one of the recent issues of evidence-based urgent care and highlight some of the important things that have come out of that issue, the learning points and potentially practice-changing information from the piece.
We hope that the podcast will be valuable in and of itself, but it'll also whet your appetite to delve more deeply into the issue, to hone your practice, and even get some CME credit.
And even if you've read the issue already, Joe and I hope to reinforce the important points and solidify important concepts to improve your learning as a result.
If you create an account at ebmedicine.net, you can subscribe and purchase the issue. You can check out the interactive clinical pathways they have there, and you can get up to 4 hours of CME credit for completing this one issue. Hey, you've already started your CME journey by listening in.
And you can also subscribe for a full year so you won't miss anything. At the regular price, that's a great value. Be on the lookout for occasional promos, sales, and special offers to make it that much easier.
Hi, everyone. This month, we're going to be reviewing the September issue of Evidence-Based Urgent Care, which discusses the urgent care management of abnormal uterine bleeding in the non-pregnant patient. We'd like to thank our author and reviewer.
And this issue was written by Dr. Michael Hurd, who is an ACOG fellow and the medical director for the Hurd Institute in Houston, Texas. Portions of this issue were adapted from the August 2021 issue of Emergency Medicine Practice on the same subject by Drs. Tazeen Abbas and Abbas Hussein from Hostel Northwell, which is in Staten Island.
And our peer reviewer was Dr. Amy Moyers-Brenwald, who is an assistant professor in the Department of Family Medicine at West Virginia University in Morgantown.
Great. Just one little announcement here. EB Medicine will be at the Southeast Regional Urgent Care Association's inaugural conference, which is actually being scheduled and arranged by yours truly. That will be October 24th to 26th in Atlanta, Georgia. It's going to be a really cool conference with a lot of good exhibits. So we encourage you to go and meet EB Medicine there. Joe and I will both be there as well. So if you want to reach out and talk to us and meet with us, that would be great. For more information about the conference, go to SERUCA, that's SERUCA, Southeast Regional Urgent Care Association.org, and be sure to look for us there.
I'm really looking forward to this, Tracy. Gosh, you guys just got started and having a conference so soon, and the schedule looks great. Going to be a lot of fun. Hopefully,
Thanks,
tons
Joe.
of people get to come. Okay, well, let's get into it. I'll start with a little intro, etiology and pathophysiology. Abnormal uterine bleeding, or AUB, affects about a third of women at some point in their life, and severity can range from minor to life-threatening. Causes can be benign or malignant. The issue talks about this acronym that's used by OBGYNs and other acute care clinicians, PALMCOIN, P-A-L-M-COEIN, that's useful for remembering all the potential causes, kind of the differential diagnosis of AUB. The PALM part, P-A-L-M, comprises the structural causes, and that includes polyps for P, adenomyosis, leiomyoma, and malignancy, so that gives you the P-A-L-M. The COIN part comprises the non-structural problems and stands for coagulopathy or coagulation problem, ovulatory dysfunction, endometrial, iatrogenic, and, as always, not otherwise classified. Being as specific as any one of these really goes beyond urgent care scope, but it would sometimes kind of distill it down to structural versus non-structural, and that's helpful. It also helps us determine whether the patient can be discharged from urgent care or whether they need to go to the ED or whether they need something even more urgent where they need to call EMS. Of course, pregnancy-related bleeding is evaluated and treated much differently. So one of our first steps, and we'll talk about this in the evaluation section, is to be sure the patient's not pregnant. That's not one of the PALM-COIN acronym letters. And also be sure the bleeding is coming from the uterus and not the GI or GU tract, which, I'd have to say in practice, sometimes that comes up. Patient doesn't know exactly where it's coming from. And that, of course, requires a physical exam. The differential diagnosis does tend to include some things which are based on the patient's age and the level of maturity of the hypothalamic pituitary ovarian axis, which kind of regulates the hormonal function. And a lot of the hormonal related bleeding comes from that. And that's going to be in women who are under 18. Structural disease is common in women between 20 and 40 or 19 and 39. It's often quoted. And then we worry about more structural disease and even endometrial cancer in patients who are older and also perimenopause or menopause. So in addition to that differential diagnosis to go along with the algorithm, there's also this age-related common things that can help you structure your differential. Tracy, tell us what the urgent care evaluation of patients is with dysfunctional uterine bleeding.
All right. Well, this is huge. It was like 4 pages in the issue. So I'm going to be a little brief about it. But if you really want an in-depth review, I suggest you go to the issue and scour it more closely. But with all patients, let's start with establishing stability. That's probably the most important thing you want to do. You want to make sure that the patient is hemodynamically stable and whether or not you're going to have to send this person out emergently to the hospital. If you decide that they're not hemodynamically stable, do your best to try and resuscitate them if you can. I mean, if all you can do is lay them flat, then lay them flat. But if you have that capability of being able to start an IV and maybe put some IV fluids in, then go ahead and do that before you transport them to the hospital. Once you've decided, hey, you know what, I think I can treat this patient in urgent care, you want to do your basic history and physical. You want to focus on a gynecologic history, ask them when their last period was, when's the last time they were pregnant, if they've ever been pregnant, have they had spontaneous miscarriages, what their menstrual cycle's like. Do they have once a month, once every 6 weeks? Are they totally irregular and have no idea? Do their periods last for 2 weeks at a time, or is it just a day or two? Is the bleeding acute or chronic? There's a big difference between I've been gushing for 3 hours versus I've been using a pad for 6 weeks. So try and nail that down a bit. Are they on any contraception? And if so, are they on hormonal contraception? What is the dose? Are they on a high dose pill, a low dose pill? Are they wearing a patch? Do they have a ring? Do they have an IUD in place? Because that might indicate a problem with the IUD that would be causing bleeding. Have they had vaginal trauma? And I find a lot of people are very kind of wary to tell you about this. You really have to specifically ask. I call it sexual misadventure. Was there some sort of accident when you were having sex that might have resulted in some sort of trauma? Do they have any sort of an infection? Was there some abscess or Bartholomew cyst down there that's now ruptured and bleeding? What is their STI history? If there's someone who's a sex worker and they have multiple STIs, that may be contributing to bleeding. Or have they never had any sort of STI that would kind of make you think in an opposite direction? Are they on any medications? Older people with heart disease on Plavix, somebody who takes an aspirin a day, somebody who's on a DOAC or warfarin, all of those things are very important. And sexual history. So here's a board question for you. If anybody wants a free board question to answer. Postcoital bleeding may be associated with chlamydia in up to 40% of cases. So if you have someone who's sexually active, either with multiple partners or I don't want to say a questionable partner, but and they're having some postcoital bleeding, always think about chlamydia for that and test them for that. As I said, you're going to want to quantify the bleeding. That can be really hard. Heavy bleeding is considered greater than 80 mLs a day. So how do you do that? I mean, the blood is in a pad. You can't exactly put it in a little beaker and measure it for 80 milliliters. So you want to talk about number of pads. Again, this is subjective. Some people, they have 1 drop of blood on a pad, they're switching their pad out. Some people wait until it's really full. So you kind of have to tease that out. How many do they go through a day? Are they flooding? Is it overflowing the pad? Are they leaking? Can they make it through the night with just 1 pad? Or do they have to get up in the middle of the night and change the pad? Or are they spotting on their bedclothes? So all of those things can help you sort of quantify how much bleeding is really occurring. A lot of times people tell me how heavy they're bleeding and I ask them how many times they changed their pad today and they say none. Well, I guess that's not as heavy bleeding as the patient seems to think it is. So you really have to figure this out. Lastly, you want to see if they have a past medical history of anemia. Someone who has chronic heavy periods is probably going to have some sort of past medical history of iron deficiency anemia. Do they bruise easily, which would make you think, hey, maybe there's some coagulopathy going on here. Maybe their platelets are too low. Do they have a family history of coagulation disorders? Does von Willebrand's run in their family? Do they have a personal history of any sort of gynecologic cancer, or do they have a family history of gynecologic cancer? That would help you out in narrowing your differential. Again, physical exam, you want to start with vitals. Again, I'm saying this halfway through the history or towards the end of the history, probably should have done the vitals first when you're figuring out stability. You want to make sure you get a temperature, you want to make sure you get a pulse, and you want to make sure you get a blood pressure, because all of those things will tell you if the patient is hemodynamically stable. And then a lot of people forget, you want to do an abdominal exam and you want to do a pelvic exam. Very important to look for other causes that might be outside of the GU tract. If you're for doing an abdominal exam, maybe they have some sort of appendix or some sort of rectal cancer that's perforated through and you might feel some masses in there, or maybe they have some advanced ovarian cancer that you can feel on your abdominal exam. Just a word about pelvic exams, always bring a chaperone. I used to think when I was young and reckless that it was okay to do pelvic exams without a chaperone. I mean, hey, I'm a woman, right? A woman and a woman. But 2 things. One, women can be unhappy with a woman doing an exam and may prefer to have a male. It doesn't happen very often, but it does. And women can also accuse women of doing things that are inappropriate during pelvic exams. So it's always good to have some sort of witness, even if they're just standing in the room. But my reason for always having a chaperone is a couple of times I've run into situations where either the patient is not cooperative and it's very difficult to do an exam and you need somebody to just there to help talk them through it, maybe hold their hands, maybe make sure that their legs are not clamping down on you, and just to hand you things. You've got a stack of swabs that you need. You've got that need to be opened, all sorts of things like that. It goes a lot smoother and a lot faster if you have a chaperone. So that's my take on having a chaperone. So please, if you have that availability, make sure you take one with you. Don't forget, during your bimanual exam, you're specifically looking for any tenderness. Do they have a chandelier sign? Is that bleeding coming right from the os or is it coming from somewhere else? And you want to look for, is there an enlargement of the uterus? If it's got a whole bunch of fibroids in it, you're going to feel those. Or is there adnexal tenderness or masses? So don't forget, you got to do a pelvic exam. I know a lot of us hate doing them in urgent care, but this is one of those instances where you really need to do it. I mean, sometimes you're going to get in there and there's going to be so much blood, you're not going to see anything. And that's okay. But, at least that gave you some good information. All right. So we're done with our history and physical. What diagnostic studies are we going to do, Joe?
Well, as we talked about, the differential diagnosis and evaluation is a lot different if the patient's pregnant. So pregnancy test is really that absolutely essential diagnostic test. And we have the ability to do that at most urgent cares or all urgent cares. In patients with heavy bleeding, most of the time we're going to be sending them to the ED or sending them on for further care. But in those cases, that's when you're going to think about getting an H&H or maybe a full CBC. If you're suspecting coagulopathy, the platelet count is going to be important, as well as some coagulation studies. Heavy bleeding may prompt you, like truly heavy bleeding may prompt you to go down that diagnostic pathway. Or like you said, if the patient notes easy bruising or other kinds of issues that make you suggest there might be something wrong with their coagulation. You also mentioned cervicitis or chlamydia or other STIs causing vaginal bleeding. And if your physical exam shows that it's just cervicitis, let's say, and the patient just has a postcoital bleeding, in that case, you can probably handle a workup in urgent care. You would do some testing for STIs. Along with that, some of us have rapid testing now. Might be able to get a diagnosis relatively quickly in that case and not have to send the patient on. As far as imaging, pelvic ultrasound is typically going to be your test of choice. Of course, we don't necessarily have that at our disposal to be able to get the test results back quickly the way we would in the ED, but a stable patient might be able to be referred for that. And then the pieces could be put together later, looking for things like the thickness of the endometrial stripe or other structural disease like fibroids or polyps or adenomyosis. All of those things can be visualized on ultrasound. So it can be helpful if there's a structural cause or you're suspecting a structural cause. So Trace, what treatments do we have in our arsenal to treat patients with abnormal uterine bleeding once we're beginning to get suspicious about what the cause might be or being more certain about what the cause is?
All right. Well, that's kind of a loaded question because you really sort of have to have a sense of what the underlying cause is before you decide what the best treatment is. And I used to shy away from this a lot in urgent care, but this is something we can really start in urgent care. You don't have to wait for that GYN appointment or send everybody to the ED. We can do some of this in urgent care.
Mm-hmm.
We talk about acuity degradation in urgent care. We're sending more and more out to specialists and emergency departments when really a lot of this stuff we can do in urgent care. And this is one of those things.
Mm-hmm.
So oddly enough, the evidence on treatment for dysfunctional uterine bleeding is actually very limited. Most of them, the thoughts and the studies are recommendations, not necessarily true evidence. And remember, when we're talking about doing treatment for this sort of thing, this is only on non-pregnant patients. That's a whole nother algorithm. So as soon as you get that positive pregnancy test, you are out of this algorithm. We are talking only for non-pregnant patients. So you want to consider the age, their risk factors, the suspecting underlying cause, and their ability to follow up with somebody. If they don't have a gynecologist and they're uninsured, it's going to be a while till they can follow up. So this is something that we can work on. Again, unstable, you're going to want to send them to the emergency department or an emergent GYN evaluation if you're able to get that. Some people have relationships with gynecologists or clinics or teaching programs that can arrange for that sort of thing. But if they're stable, a lot of them can be treated in urgent care. So the easiest way to sort this out is, do you think the bleeding is from a hormonal cause, like anovulatory bleeding, or do you think it's from a non-hormonal cause? And you want to tailor that treatment according to whether you think hormonal or non-hormonal. So think of it this way. Hormonal therapy works when anovulatory bleeding is suspected. If you have a different diagnosis, then you're probably going to want to use some sort of non-hormonal treatment, which is tailored to your most likely diagnosis. So again, hormonal, I used to think this was something that should only be done by GYN. I was always wary of writing birth control pills or any kind of hormonal treatment for anyone out of urgent care. But this absolutely can be started in urgent care as long as you think about a few things before you go and write that prescription. And then by all means, they must be followed up with GYN after you've discharged them. If you want an in-depth review on how this hormonal treatment works, go ahead and see the article, and that'll give you great information. There's actually a wonderful chart in there and a pros and cons of which ones you want to use. But in general, you want to use a combo of an estrogen and a progestin. There actually is one study. The only one that's approved for heavy menstrual bleeding by the FDA is the estradiol valerate and Dianogest, which is a combination oral contraceptive pill. This is evidence-based, and it's done as a taper. Again, the specifics are in the article with the really good chart. So if you're interested in learning how to do this, go ahead and read that issue. Contraindications for hormonal therapy, super important. Cardiovascular disease. So if you have a woman with cardiovascular disease, you're not going to want to give them hormonal treatment. Do they have a history of a thromboembolic event? So we're talking either peripheral vascular disease, DVT, PE. Not going to want to give them hormonal treatment in that case. Do they have liver disease? That's bad. Pregnancy, again, we're in a whole nother algorithm if pregnancy is here. So eliminate that one. Hypertriglyceridemia, that might be a contraindication for hormonal contraceptive pills. Age greater than 35, and cigarettes used to be a hard stop on the smoking, but now it's cigarettes greater than 15 per day. And also, if you have a high suspicion of a malignancy, you don't really want to use a hormonal treatment because it might be a hormonally responsive malignancy that you could then make worse. So if you just think it's plain old anovulatory bleeding and you're not concerned about any of these other things, you can do this hormonal therapy using oral contraceptive pills. If it's non-hormonal bleeding, if there's a lot of it and they may need a blood transfusion, well, blood is the treatment for severe anemia. You may just need to do some iron supplementation. You can use some NSAIDs. The use of NSAIDs is actually evidence-based for vaginal bleeding because it actually reduces the bleeding by up to 35%. The mechanism of action, again, is beyond the scope of my podcast, but please look it up if you're very interested. There's a whole cascade system in there that explains why it works. And don't forget your contraindications on the NSAIDs as well. Gastritis or peptic ulcer disease, chronic renal disease, allergic to the medication. Not in the article was gastric bypass status. So you never want to give somebody that's had weight reduction surgery to their stomach an NSAID because you can cause ulcers very easily with that. Also want to use with caution in somebody who has diabetes, hypertension, or coronary artery disease. And I see this in a lot of cases. We forget there's contraindications to these things. We tell everybody, just take ibuprofen, just take ibuprofen. It's kind of a knee jerk. But, always think about these things before you tell somebody to take ibuprofen, even if it's just over the counter. Tranexamic acid. I think this is an underappreciated treatment for a lot of causes of bleeding. We talked about this during epistaxis, but it's also useful for this type of bleeding and then for trauma as well. It blocks plasminogen binding sites, preventing clot degradation. So once your clot forms, it enforces that. It's administered orally for dysfunctional uterine bleeding, and the study reduced bleeding by 40 to 50% with minimal side effects. So this is really a useful thing that we can think about using. So Joe, what do we need to think about if we have a potentially unstable patient with abnormal vaginal bleeding?
Yeah, well, making that determination is somewhat important. Sometimes it's obvious there's abnormal vital signs or tachycardia or hypotension. Sometimes the patient's vitals might be remarkably normal, but they have altered mental status or dyspnea or some other clinical determinant. So, first determine the stability of the patient. When they're unstable, first thing you're going to want to do is activate EMS. And then around the same time or soon after that, you're going to be rapidly assessing the patient. In terms of resuscitation, if you have the ability to start some IVs, you want to get a couple large bore IVs going, ideally, or at least one. You can start some crystalloid boluses if you have that, normal saline or lactated ringers to support perfusion, blood pressure, follow the vitals, make sure they're moving in the right direction. Even if the patient's not hypoxic, sometimes giving them a little bit of oxygen can be helpful because the true situation with hemorrhagic shock is that there's not enough oxygen delivery to the tissues. The SAT might be normal. There's just less blood circulating around. Then you're going to consider your ABCs. And if the patient's having difficulty breathing as a result of this or semi-conscious, you might have to assist with respirations. And in cardiac monitor is not a bad idea. Dysrhythmias and that sort of thing are typically a different sort of problem, but any kind of sick patient, unstable patient, cardiac monitor gives you at least a continuous vital sign, their pulse. And then if they happen to get more tachycardic, it's easier to recognize that quickly without having to, take a pulse or put your hand on the patient or do a full set of vitals. If all of this instability happens soon after the patient's arrival, you're going to want to try to get a quick history and physical, try to determine the bleeding source. If it's super, super heavy bleeding, you might be able to intervene and save a life. Applying direct pressure, let's say, during a pelvic exam. If the bleeding is not uterine, if it's a vaginal laceration, let's say, you could apply some pressure to it. If it's surface cervical bleeding, you could also apply pressure with a Fox swab or a clamp with some gauze on it, just like we would stop bleeding anywhere. If there's really heavy bleeding, the patient's critically unstable, and it's coming from inside the uterus, there are some reports that the cervix can be occluded with a Foley catheter balloon, either a pediatric or adult Foley. Somewhere in between 3 to 30 mLs of fluid should provide significant enough occlusion, basically, or tamponading the outflow of the blood. During your pelvic exam, you can begin to inflate the balloon and see it slowing down and hopefully eventually stopping before you get to that 30 ml maximum volume. Once we have the patient in the ED, and I think we'll see which way urgent care goes, it might be that there's some high acuity urgent cares that would do this sort of thing, but we're going to be thinking about IV estrogen or procedural interventions such as calling interventional radiology to do an embolization. And then rarely you'll see the gynecologist take these patients to the operating room when the bleeding just can't be stopped. And when the decision is made that removing the uterus is the right thing, that they'll go for hysterectomy. That's kind of your acme treatment and your last resort, but it's always there to control the bleeding, obviously. How about special patient populations or situations that are out of the norm, Tracy? Anything we and clinicians need to keep in mind in that regard with AUB?
Yeah, definitely. There's a few things. Patients on DOACs actually, believe it or not, have a minimal increased risk of vaginal bleeding compared to controls. There are a few studies done on that. Warfarin, people do have an increased risk of vaginal bleeding, but not on the direct oral anticoagulants or the novel oral anticoagulants. Younger patients may have heavier menses when they're on these medications, but no major bleeding, which has required intervention, has been documented in the past. Oddly enough, Pixaban seems to be a little less likely to increase menstrual bleeding other than rivaroxaban. So if you're considering starting somebody on one of these medications for DVT or something like that, and they have a history of heavy bleeding vaginally, you might want to choose the Apixaban. Apixaban is less likely to increase heavy menstrual bleeding than rivaroxaban. So pro tip here, if you have somebody who's got a DVT that you're thinking of starting on one of the DOACs, ask about their menstrual history. If they have heavy menses, you might want to choose Apixaban over the rivaroxaban because it's less likely to cause bleeding. Prepubescent girls, they do come in with some bleeding. If they're not menstruating yet and they have vaginal bleeding, you want to think about a foreign body. Sometimes children will place things in their vagina that you have to go looking for that can cause some trauma or some chronic irritation that might cause bleeding. Hematologic disorders such as von Willebrand's may cause bleeding in the vaginal area even before the patient develops their menstruation. Trauma, structural disorder, don't forget about precocious puberty, which we can see in the emergency department or in the urgent care every once in a while. Mm-hmm. Cancer, sarcomas and strange sorts of cancers in children can present with vaginal bleeding. And please don't forget about abuse or sexual assault can occur in the underage population that can account for vaginal bleeding. So always keep that in the back of your mind. For a child, you want to make sure in urgent care you're only doing an external exam. This exam can really be traumatic to kids. So if a pelvic exam needs to be done, you want to make sure that it's done by someone trained to do this in children. They may need to have general anesthesia or at least conscious sedation so that it's a little more tolerable for them. Again, if you have trauma, keep that high index of suspicion for sexual assault or abuse, both in kids and grownups. You may need some ED evaluation for severe injuries. A lot of times injuries here are very hard to control the bleeding. They can be hard to suture, especially if you're not experienced in doing such things. Minor injuries like small straddle injuries or, like I said, sexual misadventures or things like that. You can just provide some local care. If they're having trouble urinating, you can have them urinate through warm water. I tell them to take a glass of warm water and just sort of pour it over as they're trying to urinate, which will make it easier. Or they can urinate in a tub with some warm water and it makes it a lot easier. Ice packs can be applied to the area and make sure you do some analgesia, either with Tylenol or ibuprofen. This is helpful. I would not recommend doing any topical stuff like Vagisil or any topical lidocaines or anything like that because they can actually cause a lot of irritation. I know I'm going to regret this, but I'm going to say I've never seen this acutely in the urgent care or the ED because every time we say something like that, I see one like 3 days later. But be aware of its existence. There is a cultural or religious process called genital mutilation. There are various types of different procedures and amounts of removal of the area, but it involves removal or suturing of certain areas of the external female anatomy to reduce sexual enjoyment or to prevent sexual activity in females. Acutely, it can result in some bleeding. It can result in infection or pain. Chronically, it can result in all of these things from scarring. It can cause some urinary issues. This is a really interesting topic. So if you're interested, I really encourage you to read more about this practice and its complications. Piercings, actually not even mentioned in the article. People do a lot of genital piercings. I've seen a few complications from that where there's either bleeding or swelling or infection. So these things can cause bleeding in the genital area. And again, sexual abuse and assault, please, if you suspect it, make sure you follow up on it. Just don't write it off. Send them to a facility where there's a sane nurse, someone who's skilled in doing exams of this nature and making sure that they can collect any evidence if it's required and get the patient treated appropriately. Joe, are there any controversies or is there any cutting edge new stuff that we should know about with this topic?
Yeah, a couple of cutting edge things, actually. We talked about using hormones to suppress abnormal uterine bleeding in patients. And so usually we're thinking about prescribing some sort of a pill medication for these patients. And there are hormonal IUDs. I think we're starting to see those more and more rather than just the inert device that's just more of a structural thing. You don't necessarily use a hormonal IUD, but there is a new medication. It's a intrauterine system that's placed similar to an IUD that contains levonorgestrel, and it can help suppress abnormal uterine bleeding on a hormonal basis. This is actually becoming first-line treatment in OBGYN offices, and so we may begin to see that in our practice as well. There's a medication called elagolix. This was just approved by the FDA in 2020. I was really hoping we could avoid reviewing the pathophysiology or the physiology of the menstrual cycle, but really quickly, gonadotropin-releasing hormone is secreted by the hypothalamus, which then triggers the pituitary to secrete FSH and LH. This new medication actually turns off the secretion of gonadotropin-releasing hormone. And so everything kind of stops. In most situations, there's going to be add-back hormonal therapy with estrogen and progesterone to replace those non-secreted endogenous hormones. So a little bit more complicated. Why there'd be an advantage to it, I'm not really sure yet. And obviously, it's a relatively new medicine, probably not something we're going to be doing right away, but it is one of the cutting edges. We can see what happens. Maybe it'll be superior to other treatments. So how about risk management pitfalls? It sounds like there's a lot of things we need to consider. What do clinicians need to keep in mind on a risk management basis?
Oh, definitely. Whenever there's bleeding or whenever there's something that has to do with reproduction, there's always medical legal pitfalls involved with this sort of thing. Number one, always get a pregnancy test. I get a pregnancy test in anyone that I have any concerns about between ages 10 and 60. It wouldn't be the first time that somebody with precocious puberty at age 10 got pregnant. And it wouldn't be the last time that someone was trying to do some sort of IVF or something in their 60s. So absolutely make sure if you have any concerns, you get that pregnancy test 10 to 60. I cannot tell you how many immaculate conceptions I've had in the course of my career.
Yeah.
Even if they're not sexually active, because some people don't really know what that means. If they've had a bilateral tubal ligation, maybe it failed, maybe it wasn't done properly. Their husband had a vasectomy, don't believe it. So patients really can have a really poor understanding of these things, and you can't miss pregnancy. It is my habit. Any patient that has some sort of abdominal pelvic complaint gets a pregnancy test. You got to know this for sure, because again, it changes your complete way of thinking and it changes what algorithm you're going to follow. Again, must do a pelvic exam. Even if they tell you I'm just spotting, that's not good enough. You can't get away with just history and you can't get away with just self-swabs on this one. The only exception would be obviously if you have a really unstable patient and you're sending them out, you don't want to waste time doing an exam. Someone else is going to do it once they get to their destination. You can forego it on that case, but just get them where they need to go in that case. Always make sure straddle injuries can urinate before leaving the clinic. They will come back and need a Foley if you don't do that. So if you have some sort of straddle injury, a kid, grown up, whatever, make them pee before they leave the department. Otherwise, you're asking for trouble and they're going to come back. And then it'll also prompt you to say, look, are you having trouble peeing? Here's what you can do to make it easier. Use that warm water, pee in a bathtub, that sort of thing. Put some ice on it before you're going to go. Don't assume bleeding in 50 years old is just from menopause. You have to exclude pregnancy. Again, I've seen 52-year-olds who are pregnant. So please make sure you do that pregnancy test. And if it's negative in a 50-year-old, it's malignancy until proven otherwise. So that's someone you're not going to give that hormonal therapy in until you've excluded malignancy. Make sure they know that this is potentially a serious condition and they absolutely have to see a gynecologist for further evaluation and treatment. You can save a life figuring out that they have some sort of uterine or cervical malignancy early on in the game. So make sure that they understand. Very, very important to follow up. If you are using that hormonal treatment, remember I mentioned you got to exclude those certain things such as pregnancy. Again, make sure you review the risk factors for using hormones such as coronary artery disease, pulmonary embolus, and those sorts of things. And please screen for abuse and assault in both children and adults if you have any trauma. Patients on warfarin with increased bleeding, make sure you do an INR, even if it's been done recently. They may tell you, oh, I had my INR last week and that was normal, but they're not going to tell you they ate grapefruit 3 times a day for the following week. So you need to get that INR when the bleeding occurs. I frequently get that. People will tell me, I mention, you really need lab work for this condition. And they say, oh, I had lab work 3 weeks ago and I was good. It's like, well, you weren't sick 3 weeks ago. You're sick now. So you need new blood work now. Same story for bleeding. You want to repeat vitals. That's a good one. You're sitting there with that patient in the department for an hour with vaginal bleeding while you're doing your evaluation and getting that pregnancy test and doing all those things. Repeat the vitals. This is something in the emergency department is done sort of inherently. Every time the nurse walks by, they do the vitals. But in urgent care, we do it once and we're done. We don't generally do a second set of vitals before we send somebody out. But if you have somebody who's bleeding that may potentially become unstable, please get a second set of vitals. If the patients come back for 3-4 times with vaginal bleeding, that's a red flag. You want to reassess them for blood loss and make sure that you get a prompt evaluation by GYN. So, Joe, are there any points and pearls in this issue that we should talk about?
Sure. Well, remember, abnormal uterine bleeding can affect up to a third of women at some point in their lives, and half of our patients are women, maybe more. So we're going to see this. We need to be prepared. Think about that palm coin classification system. You may not be able to whittle it down entirely, but it can keep you mentally organized when you're going through your differential, and you might be able to make a diagnosis of one of those in urgent care and not necessarily have to refer for diagnosis. Also, there's that age classification, goes in more in depth in the article, but that age classification can also structure your differential. Bleeding that is unpredictable, that happens irregularly, is a little more suggestive of ovarian dysfunction and hormonal causes. Postcoital bleeding, we talked about, it can indicate an STI, basically cervicitis, but it can also be seen with hormonal changes or malignancy in the early stages before the bleeding becomes more brisk. And then women who have a history of heavy bleeding since their initial period, or they have those associated symptoms, like we talked about, easy bruising or frequent epistaxis, they may need to be evaluated for an underlying bleeding disorder. So that's when you're going to think about getting your coags and a CBC to get their platelet count. Tracy, how about some final pearls?
Yeah, I actually want to mention again with the heavy bleeding since menarche, I just redid some of my boards and that was actually a question on there. 17-year-old who's had heavy periods since menarche presents to the emergency department with now heavy bleeding. And the answer was she probably has von Willebrand's. So that's something that you can think about for future board questions. Or, if you have a teenager with heavy bleeding, always ask about the coagulopathies or inherited coagulation disorders. So sure. Final pearls. Again, famous author and lecturer in cardiology, Amal Mattu, said, if you say something in your lecture 5 times, people will remember it. Can't stress it enough. Pregnancy test, pregnancy test, pregnancy test, pregnancy test. If you think someone has abnormal vaginal bleeding, please get a pregnancy test because that can totally change your thought process. Quantify bleeding. Again, we talked about how hard it can be to do that, but it's very important to try and get out of the patient how much bleeding you think they're really having. Remember, greater than 80 mLs a day is considered heavy bleeding. Please don't skip the pelvic exam. Very important to do that pelvic exam on anybody with bleeding for no other reason than to identify and to ensure where the bleeding is actually coming from. Mm-hmm. And that'll also help you quantify the bleeding as well if you see it yourself. Bring a chaperone. Always helpful to have an extra pair of hands in the room. CBC to evaluate for anemia and thrombocytopenia. You really don't need to do this on everybody, but you should think about it. Even if you have to send it out and get it the next day. I mean, my turnaround time in my lab is about 24 hours. Occasionally we get it the same day, but most of the time it's 24 hours. It's still helpful, especially if it's chronic bleeding or you suspect some sort of platelet disorder. It's a helpful thing to have. Don't forget, your hemoglobin may not drop right away. Those of us who have done emergency medicine before realize that usually that first CBC is kind of normal. They're having a brisk bleed because after you resuscitate them and fill them up with all sorts of IV fluids and give their system a little bit to equilibrate, that's when your hemoglobin and hematocrit drop. So sometimes it's useful to get a second one hours to days after the first to see if it drops and how much bleeding there actually is. Most of these patients should follow up with a gynecologist in a few days. Make sure you stress the importance of this, especially in someone that you think might be a malignancy. My go-to phrase that I put on the end of my discharge notes is, you have not had a comprehensive GYN evaluation for your condition. I am not a gynecologist. I don't play one on TV. Kidding. I don't say that. But further testing and treatment may be required. Very important you follow up. And I usually put a time on it within a week, within 48 hours, within a month. If they don't have a GYN, make sure you refer them to someone or give them some information on how to acquire a GYN. Even if you just tell them, call your insurance company and ask them to pick you a GYN or who participates with your plan. All right, let's wrap it up. You have anything else you want to comment on, Joe?
No, well, there's lots of tasty tidbits in this issue. We've hit on the high points and just basically scratched the surface. You'll find useful charts, in-depth explanations, tidbits, coding challenge, and even your CME questions there, which reemphasize the learning and also give you your CME credit. This is a really comprehensive review of something we can definitely do better in urgent care. Go ahead and check it out.
All right. Well, we thank you for listening and we hope you enjoyed it. And we look forward to seeing you next month.
Take care, everyone.
I want to thank everybody for listening to this month's evidence-based urgentology podcast. Just a reminder that subscribers can go to evmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to the site, that's evmedicine.net, to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.